evening. On behalf of Sutter Health, welcome to tonight's online session about shoulder pain. If you've got a bum shoulder, this is the right place to be. The orthopedic program at Sutter Santa Rosa Regional Hospital is one of California's best. And tonight you'll learn about the causes of shoulder pain, along with some of the latest innovative treatment options from Dr. Neema Pourtaheri. After his presentation, we'll have a Q&A session where he'll answer your individual questions. Now, due to the coronavirus, we've pivoted our regular in-person seminar to this online webinar format. So just a quick matter of business on how online webinars work. When you have a question for the doctor, anytime during the presentation, just scroll your mouse or touchpad over the Q&A button at the bottom of your screen. Click Ask a Question and then type it in. We'll save the questions for the Q&A session after his presentation. And once the entire webinar is over, a survey feedback form will pop up in your browser so you can contact the doctor's office directly, get additional information, or request an appointment. And just in case you missed the survey feedback form tonight, we'll email it to you tomorrow. So let's get on with the show. We're really lucky to have Dr. Pourtaheri here tonight. He's a board certified orthopedic specialist, fellowship trained in shoulder and elbow surgery. He's an undergraduate in biomedical engineering from UC Berkeley. He earned his medical degree at Tulane University in New Orleans, completed his orthopedic surgical residency at St. Joseph Regional Medical Center, and he was fellowship trained in shoulder and elbow surgery at Beth Israel Medical Center in New York. He's published several award-winning works on orthopedic conditions and treatments, a member of the prestigious American Shoulder and Elbow Society, and a reviewer for the Journal of Shoulder and Elbow Surgery. But more important than all of that, he's performed hundreds of shoulder and elbow surgeries with incredible outcomes. Patients love Dr. Pourtaheri because he's known for resolving their pain. And despite his busy schedule, we're grateful that he could make it tonight. So with that, let's welcome Dr. Pourtaheri.
Good evening. Sean, thank you for that wonderful introduction. It's great to be here tonight and talking about one of my favorite topics, shoulder pain. I'm going to be talking tonight about common causes of shoulder pain, and I'd like to thank everybody for attending my webinar tonight. I'm going to share my screen now. Sorry. So once again, my name is Dr. Neema Pourtaheri. I'm a shoulder and elbow surgeon at Santa Rosa Orthopaedics, also known as the Bone Palace. So this is an outline of what I'm going to talk about tonight. First, I'm going to talk about rotator cuff tears and proximal biceps tears. And then I'm going to move on to talking about shoulder bursitis, also known as shoulder impingement. And then I'm going to talk about shoulder arthritis. And at the end, we're going to reserve time to answer questions from the audience. So rotator cuff tears. This is an outline of what I'm going to talk about with regards to that subject. I'm going to start out by talking about anatomy and function, and then symptoms, types of rotator cuff tears, and then treatment for rotator cuff tears. So what is a rotator cuff? It's a term given to a group of muscles and their tendons that act to rotate and stabilize the shoulder. So this is a picture of the 4 rotator cuff tendons in the shoulder. Their names are the supraspinatus, which is actually the most commonly torn rotator cuff tendon, followed by the infraspinatus, teres minor, which is the least commonly torn rotator cuff tendon, and the subscapularis tendon, which is actually the largest. So in the middle here, we have a front view of the shoulder. This is the ball side of the shoulder, and this large tendon on the front of the shoulder is the subscapularis tendon. The supraspinatus can be seen here at the top of the shoulder, okay? And then on the right here, we have a back view of the shoulder showing the infraspinatus tendon, which is also rather large and covers the back of the shoulder. And the most bottom rotator cuff tendon is the teres minor, outlined here. So this is a side view of the shoulder. You can see the 4 rotator cuff tendons once again here. This is the subscapularis tendon. This is the supraspinatus tendon at the top. And then you have the infraspinatus. And at the bottom here, you have the teres minor. I'd like to point out in this image, this structure right here at the front of the shoulder between the supraspinatus and subscapularis tendons is actually the long head of the biceps. And this is a common cause of shoulder pain, and it exits the shoulder joint here and wraps down the front of the arm, and is a common cause of arm pain in individuals. So what does the rotator cuff do? So one of its primary functions is to hold the head of the humerus, the ball side of the shoulder, in the socket of the shoulder. Oftentimes, the golf ball and tee analogy is used. The reason being, as you can see on this x-ray here on the left, the ball side of the shoulder is twice the diameter of the tee, also known as the socket side of the shoulder seen here. So the rotator cuff is really essential in providing balance to the shoulder joint and allowing the ball to balance on the tee, so to speak. Another essential function of the rotator cuff is for shoulder rotation and arm elevation. It really is crucial for that. Without the rotator cuff, the ball, the humeral head side of the shoulder, would slide out of the socket, and this would decrease the efficiency of the deltoid muscle in raising the arm. So in this image here, we have a rotator cuff tear. This is at the supraspinatus at the top of the shoulder, and this is a full thickness tear of the supraspinatus outlined here. This is where the tendon normally should attach on the ball side of the shoulder here. This is a side view of the rotator cuff here. This is also a tear of the supraspinatus tendon. The tear is outlined here. Once again, you can see the long head of the bicep intimately associated with the rotator cuff tendon. So rotator cuff tears, this is a very common cause of pain and disability. It affects about 2 million people in the United States annually. So how do we diagnose it? Starting out by a history in the office, a physical exam, and then imaging. So history, rotator cuff tears definitely occur more often in a person's dominant arm. They're more commonly found among people over the age of 40. It's not uncommon for folks to have pain that's worse at night and interferes with sleep. Folks also have difficulty lifting things, particularly overhead, and rotating the arm. Folks also have difficulty performing activities of daily living, like combing their hair or getting dressed. I would say the most important risk factor with regards to rotator cuff tears, unfortunately, is age. Greater than 40% of patients over the age of 65 have a rotator cuff tear of some sort. Other risk factors are overhead activities. Folks like painters, carpenters who do a lot of overhead work do have a higher incidence of rotator cuff tears. Folks who play overhead sports, particularly at a competitive level, like baseball pitchers and tennis players, also have a higher rate of rotator cuff tears. Physical exam. For the most part, folks who have rotator cuff tears have weakness with forward elevation, which is this action in the left image here. They have weakness raising their arm above their head, or external rotation, which is pictured here on the image on the right, turning your arms out. MRI is great at diagnosing rotator cuff tears. On this MRI here, this is the supraspinatus tendon, and you're supposed to have a nice black tendon coming all the way out to the edge of the shoulder here. And in this picture, you don't. You have a full thickness tear, which is this white spot here on the MRI. So types of rotator cuff tears. There's two types: acute traumatic rotator cuff tears and chronic. So acute tears are characterized by an injury of some sort, such as lifting something heavy, falling, or after a shoulder dislocation. It's typically seen in older patients, although it can be seen in patients younger than 30 years of age. This is usually associated with a significant injury like a motorcycle accident or a fall from greater than 10 feet. Degenerative tears. These are tears that occur gradually in the tendon over years through repetitive stress to the tendon itself, or from bone spurs on the undersurface of the shoulder rubbing against the rotator cuff tendon. This is a picture in an animation of a bone spur. This is the roof of the shoulder called the acromion, which is part of your shoulder blade. And here you can see a bone spur on the undersurface. This bone spur, as you can see, if one were to lift their arm, can rub against the underlying rotator cuff and cause either a partial or full thickness rotator cuff tear. So full thickness versus partial thickness tears. What I mean by a full thickness tear outlined here on the right is that the tendon is torn through the entire substance of the tendon, full thickness. And on the image here, we have a partial thickness tear. The tendon is torn, but not through the entire thickness of the tendon. So full thickness tears definitely progress more quickly as far as size goes. And partial thickness tears are usually more stable and progress more slowly and are typically safer to be treated without surgery. So this is something important I'd like to talk about with regards to rotator cuff tears. Unfortunately, and I get this question all the time, once a rotator cuff tendon is torn, for the most part, it is torn. It does not heal, unfortunately. The reason being rotator cuff tendons, where they typically tear, is where there's poor blood supply in the shoulder, and without blood supply, tendons, bones, they can't heal. So this tear, like a tear in fabric in the rotator cuff, will only get bigger with time. So non-surgical treatment options for rotator cuff tears. Activity modification. What I mean by that is avoiding overhead lifting or heavy lifting. You can try anti-inflammatory medications like ibuprofen or Aleve. Cortisone injections, some doctors do inject people with rotator cuff tears with cortisone. It's a bit controversial. It's not my preferred method of treatment, but some doctors do that. Physical therapy. It's important to note, physical therapy does not fix the tear, but in some people, it can make them feel better by strengthening the other rotator cuff tendons that are not torn. So these are some exercises I give folks in the office. These are very basic rotator cuff strengthening exercises that can be done with bands in a doorway, with a doorknob, to strengthen the rotator cuff tendons. This is a picture of other types of bands that can be used to strengthen the shoulder. And here's a picture of a patient doing external rotation exercises to strengthen their posterior rotator cuff. So surgical treatment. Who gets surgical treatment? Full thickness and partial thickness rotator cuff tears that fail to respond to non-surgical treatment like therapy, medication, rest. Also very important to know, all acute traumatic rotator cuff tears
particularly in folks under the age of 60, should be treated operatively. The reason being is the tendon was attached one day, and then through trauma, the next day it's not. And these folks do not respond well to non-operative treatment. It's also important to know, in order to qualify for surgery, as far as your rotator cuff tendons go, you need to have good muscle and tendon on the MRI. Folks who do come to me oftentimes have very large rotator cuff tears, and sometimes the tendon quality is not good, and there's significant atrophy, and unfortunately, these cannot be fixed. Shoulder arthroscopy. This is the mainstay of operative treatment of shoulder rotator cuff tears. This is an outpatient surgery, also known as same-day surgery, where the rotator cuff tendon is fixed through small incisions in the shoulder using specialized instruments and cameras. A nerve block is administered by the anesthesiologist on the day of surgery, which helps control a lot of the pain in the first 24 hours of surgery. So this is a picture of the type of portals, incisions, small arthroscopic incisions that we make during shoulder surgery. One is typically made on the front, another on the side, another on the back. Sometimes, depending on the complexity of surgery, you do need to add extra portal incisions. This is an animation of shoulder arthroscopy. It involves a camera to see what you're doing in the shoulder and take pictures. An arthroscopic pump, which actually fills the shoulder with fluid so that you can see. And then motorized instruments to perform the surgery. This is another animation of an arthroscopic shoulder surgery. This is a pump used to fill the shoulder. This is a camera here to see inside. And this is an instrument used to repair the torn tendon here. This is an intra-op picture of a shoulder arthroscopy. This is a camera here. And the camera actually has a pump attached to it. That's what this fluid line is that inflates the shoulder so you can see. And here is a motorized shaver that is used during surgery. This is an intraoperative photo of a full thickness supraspinatus rotator cuff tear. This is a U-shaped tear of the rotator cuff tendon here. This is the tear outlined here. And this tendon is supposed to be all the way over here on the greater tuberosity. This is the point where the rotator cuff tendon attaches on the humerus bone. As you can see here, sutures have been placed in the tendon to anchor it to the bone. This is an animation of the anchor and suture placed in a torn rotator cuff used to repair the tendon down to the bone. Here's a picture of the finished product showing the tendon being passed through the bone and an anchor pushing the tendon back down in the bone so it can heal. This is an intra-op picture of a rotator cuff repair surgery. These sutures have been used to fix the tendon back down to the bone. So it's important to talk about biceps tears. These are frequently seen during surgery. And when I mean biceps, I mean the long head of the biceps that actually anchors at the top of the shoulder and travels at the front of the shoulder. These tears are frequently seen during surgery and need to be addressed. I use a biceps tenodesis procedure where the biceps is re-anchored in the armpit with an incision about 1 inch. Here's a picture of the long head of the biceps. As you can see, it travels down the front of the shoulder and originates in the joint of the shoulder here. Here's a picture of a biceps tenodesis. This is where the long head of the biceps typically tears and is seen during surgery. And this segment here is removed and the biceps is re-anchored right here I use a small metallic button, which is titanium. It's no bigger than a piece of rice. and the tendon is sutured in a manner like this and tied down to the bone. So the goals of rotator cuff surgery, really pain relief. It's an excellent operation, greater than 95% pain relief. Also improved shoulder strength once you've recovered. And really another goal of rotator cuff surgery is to prevent tear progression. You know, fixing a tear when it's small is your best chance of fixing it. When these tears get bigger, they develop atrophy, and you have poorer tissue quality that occurs with time. It becomes more difficult to fix, if not impossible. So rehab after surgery, folks are typically immobilized in a sling for 6 weeks. We limit their lifting for 3 months and therapy for usually at least 3 months after surgery. Another common cause of shoulder pain is shoulder impingement and bursitis. So this occurs with inflammation of the tendons in the shoulder, and is typically a result of overuse, although sometimes can occur after trauma. And what folks get is they get an inflammation, as you can see here, of a bursa, which is a normal fluid-filled sac that is between the rotator cuff tendon and the roof of the shoulder. And this swollen bursa can cause a lot of pain and inflammation in the underlying tendon. This pain is usually worse with overhead activities. So symptoms, pain that's usually exacerbated by activity, particularly overhead activity, and relieved with rest. The pain is typically partially or fully relieved with oral anti-inflammatory medication like Aleve or Advil. So non-op treatment for shoulder bursitis, activity modification, really the avoidance of overhead activity and repetitive lifting. Oral anti-inflammatories like Tylenol or Advil, physical therapy, cortisone injection in the subacromial space into the bursa. This can really help some people. And then modalities like ice, ultrasound. So surgical treatment, really arthroscopic bursectomy, where through minimally invasive surgery, the bursa in the shoulder is removed, and acromioplasty, where bone spurs on the undersurface of the shoulder are cleaned out using a motorized instrument. This is a picture here, an animation of a bone spur on the undersurface of the acromion, as you can see here. And you have an underlying rotator cuff tendon here, as you can see. With overhead motion, this bone spur can rub on this underlying tendon, cause inflammation, and can even cause rotator cuff tears. Here's an intra-op picture of a shoulder. And as you can see here, there's bone surfaces on the undersurface of the acromion, and they have been flattened out with a burr. Here's the rotator cuff tendon below. So rehab for these type of operations for subacromial bursitis impingement, they tend to be faster than a rotator cuff operation because you don't have to wait for tendons to heal. Usually folks are placed in a sling for 2 weeks and they start therapy 2 weeks after surgery. So shoulder arthritis, this is a very common cause of shoulder pain, particularly in folks over the age of 60. This is an animation of shoulder arthritis. All joints in the body have a smooth white covering, similar to this here. But as you can see here, the surface is very rough in this animation. This is shoulder arthritis. Here's an intra-op picture of a shoulder. You have the ball side of the shoulder and the socket side of the shoulder here. And you're supposed to have a nice white surface, and you have absolutely none on both surfaces of the joint here. This is a severely arthritic shoulder, and this is actually exposed underlying bone on both sides of the shoulder. So these are 2 x-rays of the shoulder here. On the left, this is what a normal shoulder x-ray should look like. You have a nice round shoulder. You've got a nice joint space between these two bones here. This is the joint space here. On the right here, though, in sharp contrast, you can see that the ball side of the shoulder has actually become more box-like, and there are large bone spurs on the bottom of the shoulder here. There's virtually no joint space left in this patient here as well, and you can see a severe thickening of the bone on both sides. So symptoms, folks typically complain of pain aggravated by activity and stiffness in particular. It's typically seen in folks over the age of 60, although it can be seen in younger folks. Non-operative treatment. So first line is oral anti-inflammatories like Advil or Aleve. Also physical therapy. This is really designed at stretching the tight inflamed shoulder joint capsule. Injections. This does work for some people with shoulder arthritis. So these are the type of exercises. These are shoulder joint capsule stretches that are given in the office to patients or that your therapist would be performing. And these exercises are really designed to give you more motion and stretch that tight joint capsule to help with pain relief. So injections with the shoulder, steroid is definitely the more commonly used injection type, also known as corticosteroid for shoulders. In my experience, this doesn't work for a lot of people, particularly those who have moderate to severe shoulder arthritis. PRP, this is a new technique that I use in the office as well. There's a lot of literature coming out on PRP and shoulder arthritis and knee arthritis, and it's showing a lot of promise with regards to pain relief with arthritis of the joint. Bear in mind, PRP does not help you grow cartilage. It's really to decrease pain. So PRP, what it stands for is platelet-rich plasma. Your blood is drawn in the office. It's spun in a machine in a centrifuge, and healthy cells are filtered out that promote healing and decrease inflammation. And this, in my experience, works a lot better than steroid for shoulder arthritis. Unfortunately, it's new, so a lot of insurances aren't covering it, but it does work well for some people. So operative treatment for shoulder arthritis, there's really two main types of surgery. There's shoulder arthroscopy, minimally invasive surgery, and then there's shoulder replacement surgery. So shoulder arthroscopy. This is usually reserved for cases of mild shoulder arthritis. And the idea behind this surgery is you're releasing this stiff, inflamed joint capsule of the patient to give them more motion and ultimately less pain. Obviously, they're still going to have arthritis. This doesn't add cartilage back to the shoulder, but it can help with pain relief, particularly when you're treating associated pathology like a rotator cuff tear or a biceps tear. So shoulder replacement surgery, this is a great operation. It's usually performed on patients with moderate to severe shoulder arthritis. There's 90% good to excellent outcomes. The diseased arthritic bone of the shoulder is replaced with metal and plastic implants similar to a hip or a knee replacement. And there really have been significant advances in shoulder replacement surgery and surgery techniques for shoulder replacement and implant technology over the past 10 years. So shoulder replacement surgery and recovery. So folks, they typically go home or the following day after shoulder replacement surgery. Depending on the patient's insurance or medical comorbidities, the surgery is either performed in a surgery center or a hospital. Folks are typically immobilized in a sling for 4 to 6 weeks. depending on the type of shoulder replacement. And patients start therapy within a week of surgery, and full recovery can take 6 months to a year to reach maximal medical improvement. So there's two main types of shoulder replacements. There is the anatomic shoulder replacement. This is a conventional ball and socket shoulder replacement surgery that's performed on folks who have glenohumeral joint arthritis with an intact rotator cuff. What that means is no significant rotator cuff tearing, okay? The second type is reverse shoulder replacement surgery. Now, this is a non-anatomic shoulder replacement. I'll talk about that later. Performed on patients who have arthritis and who have large rotator cuff tears that are not amenable to surgical fixation. This is a picture of a conventional ball and socket anatomic shoulder replacement. As you can see here, a white polyethylene plastic socket has been glued into the socket side of the shoulder, okay? And on the ball side of the shoulder, a metal ball and stem have been placed to replace the arthritic bone. What I've started using in my practice over the past few years, which is great, is actually stemless anatomic shoulder replacement, where you don't even need a stem anymore. You can place a metallic head with, this company calls it a nucleus. There's no stem, as you can see, and you know, there's less surgical time when you perform it this way, better fit, and definitely less blood loss. You do cement a plastic polyethylene socket on the socket side of the shoulder still, though. And then last, we have the reverse shoulder replacement. So the reason why is it called a reverse? The reason why it's called a reverse is this. As you can see here, we actually screw a ball on the socket side of your shoulder, and then we place a stem with a socket on the ball side of your shoulder. Hence the term reverse shoulder replacement. Once again, this type of shoulder replacement is done for folks who have moderate to severe shoulder arthritis and have large rotator cuff tears that are not amenable to fixation. So now we can take some questions from the audience. This is a picture of my family.
Great, thank you very much. This is terrific, and we have some terrific questions too. Why don't you unshare your screen, and then we'll go ahead and I'll ask the first question. Okay. First question is, I'll try my best with these medical terms. I've had subacromial steroid injections and they seem to help, but never really resolve the pain. Is there any risk to keep using steroid injections as my long-term treatment? I really want to avoid surgery.
So I definitely do not, I prefer not to inject folks repeatedly with with steroid. The reason being, it's not good for the shoulder joint or the rotator cuff tendon to be repeatedly injected with steroid. I definitely avoid that in my practice because it can cause long-term soft tissue damage.
Great, thank you. Our next question is, I had surgery 4 months ago. My shoulder still hurts and is worse. They repaired the rotator. I also did PT and got injections 2 weeks ago. My shoulder still feels like it's hanging and a weight on it, and I rotate it back to pop it back in place, and it crackles like the bones are moving. What can this mean?
It could mean many things. I mean, first of all, you're technically still in the recovery phase after surgery. It can take 6 months to a year to fully improve after a rotator cuff surgery. But the fact that you're getting the sensation that your shoulder is coming out of socket and clicking, that's probably not a good sign, I'll be honest with you. I'd really have to examine your shoulder to get a better idea of what's going on and understand the type of surgery you had. So it's difficult to say.
Okay, and we want to remind people too that at the end of this, there'll be a form that pops up, and if you want to ask direct questions or request an appointment, you can do that there too. All right, next question is, I'm 48 and have had both a minor cuff tear and spurs bursitis. I've been in PT for 4 months and received cortisone shots. Temporary relief, 6 to 8 weeks, but pain and weakness has returned. Primary physical activity for me is surfing. Am I looking at surgery as my only course of action?
Well, it does sound like you failed a lot of conservative measures like physical therapy, steroid injection. So, I mean, besides therapy and steroid and medication and activity modification, there's not a whole lot else you can do. So it does sound like you may benefit from shoulder surgery.
Great, thank you. The next question is, I'm a 59-year-old male. I've had rheumatoid arthritis for 45 years, since I was 14. I've had multiple joint replacements, but recently I've got big time shoulder pain. Seems like a swollen bursa or something else is the problem. I take prednisone every day, 7.5 milligrams, but 20 milligrams seems to clear this up. Any ideas?
Well, yeah, if you're having shoulder pain, so prednisone does help with shoulder arthritis pain. Statistically, rheumatoid patients definitely have a higher incidence of shoulder arthritis and rotator cuff tears than the general population. If I had to guess, you probably have both shoulder arthritis and a rotator cuff tear, which can both cause swelling in the shoulder.
Okay, thank you. Next question is, after a non-conclusive X-ray, is an MRI the next step? Physical therapy has been recommended, but without knowing the nature of the shoulder problem, it seems like the therapy may not be specific enough.
I mean, a normal X-ray, the next step would be an MRI, but honestly, you can get a lot of information from a history and a physical exam on a shoulder, and I don't always order an MRI, particularly for a patient maybe with a frozen shoulder. It's a pretty specific history and exam type, and sometimes it's better to get people into therapy early on and then maybe get the MRI later. So I don't, MRIs do give you a lot of information, but you don't always need them in orthopedics.
Okay, thank you. Here's another question. I fell and got 2 fractures in the humeral head on my left shoulder and had surgery in early April, 7 months ago. I'm experiencing frozen shoulder now and wondering how long do you think that will take to recover? The issue seems to be an external rotation and range of motion. I'm stretching and receive weekly deep tissue massage after series of PT.
So first of all, sorry that you broke your shoulder. So unfortunately, shoulder fractures, whether you treat them with surgery or without surgery, stiffness, unfortunately, is very common. What I do for my patients, both operative and non-operative fractures, are if their motion is not improving with physical therapy, then you really need to consider either a steroid injection, depending on the type of fracture it is, or surgical treatment for stiffness, particularly if you've just hit a brick wall with physical therapy and home exercise program.
Great, thank you. Next question is, I swim every other day and have had a rotator cuff tear for over 20 years. Not much pain, but I can't lift any weight overhead. Is there anything I can do to fix the overhead strength?
So swimming is great for the shoulders. It's a great exercise. So I'm not sure how much more you'd benefit from a physical therapy program. It may be a good idea to go for a few visits for therapy and then do the exercises at home. But unfortunately, I mean, rotator cuff tears come in all shapes and sizes. So I don't know what size rotator cuff tear you have. You probably have a good size one if you're having problems with weakness. And unfortunately, unless that tendon is reconnected with the bone, you're not going to regain that strength. It's a mechanical thing.
Okay, thank you. Here's another question. I'm a 71-year-old male. I've had success with PT for rotator cuff issues. Regarding working out, I have gotten conflicting advice on whether overhead press exercises when working out should be completely avoided. Should some type of overhead press be incorporated into exercising? I use a total gym, which allows a good range of motion using a glide board system.
So I think heavy overhead weights is a really bad idea. I think for most of us, lifting more than 10, 15 pounds overhead is dangerous. You don't have a lot of control with weights over the head, and it can definitely lead to rotator cuff injury. And you already have problems, so I think that's a bad idea. You can do overhead weights, but I would definitely keep it in the 5 to 10 pound range, nothing heavier.
Great, thank you. You may want to adjust your laptop to your just so your picture's more centered.
Okay.
There you go. All right, great. Next question is, I'm 4 weeks post-op for cuff repair and bicep tendon repair, and it seems like my shoulder is getting snagged more than before. Is this normal, and will it lessen?
4 weeks is really a drop in the bucket with regards to a recovery from a rotator cuff operation. And folks typically have pain, stiffness, they may feel something catching in the shoulder. So it's really hard to say. You may want to follow up with your surgeon who can examine you, make sure everything's fine. But 4 weeks, it's not uncommon to have pain and sensation of catching in the shoulder, but I would definitely follow up with your operating surgeon if you're concerned.
Great, thank you. Next question is, back in 2004 for the right and 2011 for the left shoulder tears, I was offered only PT and cortisone. I was a pre-Olympic backstroker swimmer, so this is surprising to me given these diagnosed tears increase over time. Was this due to the protocol at the time?
It's possible. I think with time, we've become more aggressive about treating rotator cuff tears. Once again, I don't know if this is a small partial thickness rotator cuff tear. I don't know if this is a big full thickness rotator cuff tear. I think I personally do treat some small partial rotator cuff tears without surgery in some folks. If you're a high level athlete, that's a different ball game with regards to what you do for them. In some cases, you're actually more aggressive about treating them. In some cases, you're actually less aggressive because of the level of play they're at. So it's just really hard to tell without knowing the size of the rotator cuff tears you had. But definitely with time, we've become more aggressive about fixing them.
Great. Next question is there any non-surgical treatment for a bone spur that is causing fraying of the muscle?
Unfortunately, that bone spur is it's a structural anomaly in your shoulder that's just not going to disappear with time. It's there. It can cause fraying of the rotator cuff and progressive tearing. And without surgery, you can't remove it. It's just physically impossible, unfortunately.
Okay, thank you. I'm going to try to do my best with this one. I've had supraspinatus tendon repair on my dominant arm. I'm starting to experience similar pain that I experienced prior to my rotator repair surgery 13 years ago. How can I know whether I have bursitis of the shoulder or if I've retorn the cuff? And most pain is with overhead motion.
I would say if you're having weakness with raising your arm out like this, against resistance or with a weight that would suggest a rotator cuff re-tear, although some people can have weakness because of bursitis and pain. I'd really need to examine your shoulder to determine that. But if weakness is typically seen with a rotator cuff re-tear and typically not seen with shoulder bursitis.
Great. Next question is, can you briefly explain what a frozen shoulder is?
So frozen shoulder, it's a very painful, disabling, progressive shoulder condition. It's most commonly idiopathic. What that means is it occurs out of the blue. It can also occur after a trauma. Having poorly controlled diabetes is also a risk factor. First line of treatment for frozen shoulder is characterized by progressive painful loss of shoulder motion. So the number one complaint for a frozen shoulder patient is pain and stiffness. I always try to rehab a frozen shoulder first with a steroid injection of some sort and physical therapy. Sometimes folks don't respond to those means. And then need surgery actually for the frozen shoulder to release the tight inflamed joint capsule. I hope that was not enough of an explanation.
Good, thank you. Next question is, I have labral tears without a rotator cuff tear. Also, there is an asmal acromial spur. I experience pain and lifting the arm is painful. The doctor I consulted with did not recommend surgery. However, could arthroscopy be used to clean out the shoulder?
So all labral tears do not need to be fixed. The labral tears that I fix in my practice are those that cause pain or instability. And what I mean by instability is a sensation of the shoulder dislocating. So usually shoulder instability is seen in folks under the age of 40. So not all labral tears need to be fixed. And as all of us age, they've done clear studies, we get labral tears, which are physiologic. So I'd really need to know a little more about your age, examine you with regards to the labral tear. With regards to the bone spur, I definitely think if that's the source of your pain, causing a lot of pain with overhead activity and on exam, then surgery to remove that bone spur can actually be quite beneficial for people.
Great, thank you. Next question is, can you explain a procedure called smooth and move? And would you recommend it for a patient 75 years old with rotator cuff tears?
I am not familiar with the term smooth and move. You may be referring to a technique called ream and run, and it doesn't work very well. It's done for people with shoulder arthritis, where you actually you ream the shoulder, smooth it out, in hopes that it will help with pain relief. And it's really a roll of the dice with regards to pain relief. A third of people get better, a third of people don't see any improvement, and a third of people actually feel worse. So that is not my preferred method of treatment for shoulder arthritis.
Great, thank you. Next question is, how do I know if I need to see a rheumatologist or a sports medicine doctor?
That is a tough question to answer. Generally, rheumatoid arthritis affects multiple joints in the body. If you're having multiple complaints of joint pain, you may want to consider seeing a rheumatologist, and they can do lab tests. But statistically speaking, if you're just having a single joint issue, you probably don't have rheumatoid arthritis. You could have shoulder arthritis or a rotator cuff tear. So I think if you're having multiple joint complaints of pain, then it's worthwhile to consider a rheumatologist.
Great. Next question is, what might clicking sounds in my shoulder indicate, accompanied by mild pain?
So clicking in the shoulder, that could be a variety of things. It could be a rotator cuff tear. It could be shoulder bursitis, which can actually cause painful clicking in the shoulder. It could be a labral tear in the shoulder. It's tough to tell. So it could be a variety of things. It's pretty non-specific.
Great. Next question is, I've had an arthroscopic surgery almost 2 years ago now and still have pain. I had a 25% cuff tear and now possible bicep tears. Will a second surgery be needed or helpful?
So I can tell you this is a common thing that I do see in my practice. Low grade, so you have a low grade partial thickness rotator cuff tear. Those sometimes, and a lot of surgeons do it, they clean out the tear, hoping that it'll heal. It does work for some people, it does, and then you avoid that recovery of being in the sling, no lifting. But some people, it just doesn't work for them. And particularly biceps tears. I would say that's the one of the top reasons for persistent pain after arthroscopic shoulder surgery is pain from the biceps. So if you're having biceps pain or if you have a biceps tear, definitely that can provide relief. And even low-grade partial thickness rotator cuff tears need to be fixed sometimes.
All right, thank you. Next question is, I was told a couple of weeks ago I have a small but full rotator cuff tear. Should I get it fixed soon or will it be okay to wait?
So you have a full thickness rotator cuff tear. The good news is it's small. The bad news, it's a full thickness tear. I don't think unless it was an acute traumatic tear, a tear that occurred as a result of a trauma, I think it's safe to wait a few months. But as I mentioned before, full thickness rotator cuff tears, these definitely progress with time slowly. So I don't think you need to do something right away, but if you don't do something, that tear will get bigger with time.
Okay, thank you. Next question is, can you please explain what a bicep lesion is and how is it treated?
So that's a great question. So a biceps lesion is a collective term that is used to describe an abnormal biceps tendon. This can be because of a variety of reasons. Number one is the biceps itself. The tendon itself can be torn. That is definitely a biceps lesion. Additionally, the biceps can be dislocated out of the biceps groove at the front of the shoulder. That is called a biceps dislocation or subluxation. And lastly, biceps tendinopathy. That is a severe inflammation that it can occur in the biceps from abnormal tendon. And all three of those are biceps lesions.
Great, thank you. Next question is, do partial rotator cuff tears heal without surgery?
So that's a very good question as well. In young people, I would say maybe, and when I say young, I mean very young, maybe in their 20s or early 30s or teens, if they have a low grade, partial thickness rotator cuff tear, there's a possibility those heal. But for most of us, myself included, if I had a low grade partial thickness rotator cuff tear, unfortunately, it's not going to heal.
Okay, thank you. Next question is, I had a proximal biceps tendon rupture. It actually relieved the pain I was having prior. After the bruising and swelling went away, seems the only issue is the Popeye look of the biceps. Should these ruptures be repaired or just left alone? Does the proximal tendon under more strain? Is it under more strain?
So that's the very good question. So you have a full thickness, long head biceps rupture. These typically occur in diseased or pathologic tendon. You can go to just lift something and you'll feel a painful pop or snap and a resulting Popeye arm deformity, which is characterized by a sagging of the proximal contour of the biceps. As far as surgical treatment goes, I only recommend treatment for long head biceps ruptures for folks who do a lot of repetitive lifting, or if they have arm cramping. That's a very important question to ask, because a lot of people who have full thickness long head biceps ruptures, they get cramping in the arm, and they need surgery. But if you are asymptomatic, which it sounds like it, and you only have a cosmetic deformity, then I wouldn't recommend surgery unless that cosmetic deformity bothers you. And some people, that deformity, that Popeye arm deformity, really bothers them, and they want surgery to fix it. But it sounds like you're okay with it.
Thank you. Next question is, I had both shoulders repaired, rotator cuff, more than a decade ago. In August of this year, I fell and shattered my left humerus and dislocated that shoulder. After surgery and PT, I'm still in recovery with that arm shoulder. Now I'm having trouble with the other shoulder. It feels like it is failing. What are my options? Your opinion on this matter would really be appreciated.
So I'm sorry that happened. That sounds like a really bad injury. As far as the shoulder that fractured, once again, you can definitely get stiffness after shoulder fractures. You need to go to PT, you need to do your home exercises. As far as compensatory pain, having pain in the other shoulder, that's actually very common, particularly after a fracture, because you literally can't use the fractured arm sometimes for months. And your other shoulder just has to do everything, and it's not uncommon to develop compensatory pain. Your other shoulder, it could be the one that didn't break. It could be because you have shoulder bursitis. It's possible you may have a rotator cuff re-tearing, which can happen after surgery. I mean, it's difficult to say. I need to examine you, get x-rays of both of your shoulders. But compensatory pain is a very common problem after a shoulder fracture.
Thank you. I have another question. I'm a 61-year-old male. I've had a couple of minor shoulder injuries in the past 18 years. The most recent, a straight arm impact while skiing 12 years ago. During the day, I have little pain except when sitting and playing the guitar for 20 minutes. I also have pain at night while sleeping on my side. What do you think this could be?
Well, based upon your symptoms, it sounds like you have a rotator cuff tear. Rotator cuff tears, it's very common to have night pain. If you're having weakness too, that would definitely be suggestive of a rotator cuff tear. So if I had to bet, I would bet rotator cuff or biceps tear in your shoulder, particularly with the guitar playing.
Very good. Thank you. Next question is, what is it about physical therapy that helps patients avoid surgery?
So so with regards to rotator cuff tears, if you have a rotator cuff tear, once again, the therapy is actually not making the tendon heal. What's happening is the rotator cuff is a group of tendons, and you are strengthening the tendons that are not torn so that you have less pain. So for some people, all they care about is pain. They're like, I don't care if my tendon's torn, doctor. I just want to avoid surgery and have less pain. So therapy can help those people. As far as frozen shoulder, therapy can definitely help some people, and they can avoid surgery through stretching exercises of the shoulder at a home exercise program. So in some cases, you can avoid surgery because of pain relief through physical therapy.
Thank you. Next question is, after an unrepaired proximal biceps tendon rupture, is the distal biceps tendon more at risk for injury or rupture?
There's been no studies showing that that's the case. That's a very good question, though. There's no studies showing that a proximal biceps rupture places you at increased risk of a distal biceps rupture or injury. Very good question.
Thank you. Next question is, why would the mid biceps be painful when there is a shoulder issue?
So the reason why is that on my earlier slide, The long head of the biceps actually originates on the top of the shoulder and comes all the way down the front of the shoulder, and it actually goes all the way down the arm, the long head of the biceps. So you can get what we call referred pain. So the problem, the structural problem, is in the shoulder itself, but because it's a continuous structure that goes all the way down your arm, you get referred pain down the structure.
Great. Next question is, why is arm pain more prevalent at night?
So that's a good question. I'm not sure of any scientific research that explains clearly why night pain is more common with rotator cuff tears. It definitely is. It probably has something to do with cytokines, but I'm not aware of any papers or looking at, but definitely musculoskeletal pain, particularly rotator cuff pain, is worse at night.
Great. Next question is, are there any special considerations if the shoulder surgery patient has experienced a stroke?
Definitely. What I'd need to know is the level of involvement of the stroke, whether their lower extremities are affected, their upper extremities, to what extent it's affected. It's very important to know because, they could be wheelchair bound from a stroke. That's definitely going to change things. They could require the use of a walker. So how are they going to get around when they're in a sling after surgery? So I would really need to know the level of involvement after the stroke. And that's really important to know before surgery because it's going to change what you do.
Very good. Thank you. This one's a little long, but I think she wants an answer. So here we go. I'm a 62-year-old woman. I had a rotator cuff surgery, full tear, in July after 2 years of many injections and physical therapy. Unfortunately, I tore my other rotator cuff 2 weeks prior to the surgery. I'm continuing physical therapy on the surgical side. I have had an MRI on the other showing a partial tear. My body really had a bad reaction when I ended up having extreme inflammation. My marker was 84 when normal marker should be 20. I ended up at the emergency room and received a prednisone prescription, which brought the inflammation markers down to 53. I have been told what I have is called old lady syndrome, arthritis, bursitis, and tendonitis. I am losing my range of motion and having difficulty driving. My doctor wants me to go to the same route as my surgical shoulder, which is 2 years of shots and PT. Should I get a second opinion?
Well, I always think it's worth getting a second opinion, and particularly if you're not comfortable with, the treatment you're receiving, or you have questions about it. I think it's always worthwhile to get a second opinion. As far as the partial rotator cuff tear goes, it really comes down to what you want to do and how much pain you're having. Partial thickness rotator cuff tears, they don't necessarily need surgery. I do not like to inject rotator cuff tears with steroids personally. I think physical therapy is a better plan for that, unless you have superimposed subacromial bursitis, which you could do a steroid injection and benefit from that. But it's really hard to say without examining your shoulder, talking to you about your shoulder. But I always think, there's no problem in getting a second opinion.
Great, thank you. Just a couple more questions. I have a partial rotator cuff tear as well as bone spurs in that shoulder. At night, I get finger tingling and numbness. I don't think it's from carpal tunnel, as it doesn't occur during the day when I'm using the arm. Can the finger tingling and numbness come from the shoulder, as I do notice when I'm awakened with such that I'm laying on that side? And if so, what is recommended?
So that's a great question. It's actually a very common question that I get in the office. So shoulder pathology does not cause numbness in of itself. For the vast majority of people, it just doesn't. So you probably either have more likely have a pinched nerve in your neck, which can definitely cause numbness down the arm or into the hand. And there's definitely a higher incidence of cervical pathology, i.e. neck problems, in patients who have shoulder problems. It's actually very common. So the numbness in your hand is not from the shoulder itself. It's probably from a pinched nerve in the neck.
Very good. Thank you. Next question is, I have an old ski injury from 25 years ago, 3rd degree AC joint separation that was not repaired. There were differing opinions on whether to repair, and it was not repaired. Does this put me at more risk? And does this put me at more risk for rotator cuff issues? Distal end with the acromion is a cosmetic issue, but I have lived with it.
So that's a very good question. So a type 3 acromioclavicular joint separation, especially 25 years ago, not a lot of people were fixing. Even now, treatment of a type 3 acromioclavicular joint injury is definitely controversial. In my practice, I recommend it for folks who do a lot of overhead work, manual laborers. They typically don't do as well with non-operative treatment. I would say if you've had this injury for 25 years and you've lived with it, I would encourage you not to consider surgery at this point. As far as propensity for rotator cuff injuries, I'm not aware of any studies showing that AC joint injuries have a propensity for, as a risk factor for developing a rotator cuff tear. But some people with type 3 AC joint injuries can definitely get fatigue in their shoulder. The reason being is their shoulder blade actually sits a little lower than their normal side, and some people can get fatigue in their shoulder, particularly those who do a lot of overhead work.
Great. Last couple questions here. What percentage of partial thickness rotator cuff tears progress to full thickness tears?
So that question is hard to answer. The reason being is there's a wide array of partial thickness tears. You could have a 5% tear. You could have a 95% thickness tear. Technically, that's still a partial thickness tear, but the grade of the partial thickness tear, the higher grade ones, are definitely more symptomatic in people, and the rate of progression is definitely higher.
Great. Last couple are just thank you. So then one person says, just wanted to say thank you, very informative. Another one says, thank you. I had shoulder surgery several years ago and now understand what went on. I feel I'm headed for surgery on the other shoulder and I feel very informed. Thank you, Dr. Pourtaheri. Let's see, another thank you. And yeah, a couple more thank you. So we'll take those and appreciate it. If anybody has additional questions, there'll be a form that pops up after this is over, and just fill it out, and you can type your question in there, request an appointment, ask any additional, request any additional information, and we'll also email you the form tomorrow. And I will give it back to Dr. Pourtaheri to sign us off.
Well, thank you very much for attending, everyone, tonight. I'm happy to answer your questions. I'm glad you found this to be informative, and I'm glad I was able to answer some of your questions.
Very good. Thank you very much, and thanks to everyone who joined us. Have a great night.
Take care.